Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former health commissioner here in Baltimore. Our goal is to bring evidence and experience to illuminate critical public health issues. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, I'm Lindsay Smith Rogers, producer of Public Health on Call, and today our topic is access to reproductive health care, including abortion, about 3 months after the Supreme Court decision to overturn Roe v. Wade. Dr. Sharfstein is joined by Dr. Reagan McDonald Mosley, an obstetrician, gynecologist, and CEO of Power to Decide. They discuss the barriers faced by people seeking abortions, growing interference with the medical care of pregnancy, and an unprecedented moment for the medical profession. Let's listen.
Dr. McDonald Mosley, thanks for coming back to Public Health on Call to check in on reproductive health care and access to reproductive health care now 3 months after the decision of the Supreme Court to overturn Roe versus Wade.
Thanks so much for having me back.
So I know you and your organization are watching very closely the consequences of this momentous Supreme Court decision. What are you seeing now around the country?
Yeah, I think it's important to note that it's going to take us a long time to study and document the full impacts of what's going on. Thankfully, researchers at the Guttmacher Institute, at UCSF's Answer, the Texas Policy and Evaluation Project, and others are working to capture the impacts of these regressive policy changes. And we here at Power to Decide are also doing our part in keeping our database, Abortion Finder, and our private patient navigator platform up to date. We're constantly tracking which health centers are still offering abortion care, which health centers are closed. And what we found so far is that just since the end of June, that 65 health centers have closed altogether or have paused services. We've also conducted research with people who've navigated the incredible journey of getting an abortion after Roe, coming from states where abortion is highly restricted or banned, and our in-depth interviews identified some important themes. The first is that people are experiencing an extreme amount of loneliness, isolation, and a lack of support since the overturn of Roe. There's significant unmet need for emotional support, as many people are afraid to talk about their experience with loved ones for fear that they'll be implicated in helping them get an abortion or get them into legal trouble. And the other thing is just that, of course, logistics and arranging an abortion has become super complicated, and that people are needing a lot of help navigating the disjointed ecosystem, connecting to appointments, funding, travel, support, and again, emotional support. And people expressed feeling information overload and wanting help to connect to the best option for care more easily.
So it sounds like where abortions have been restricted, a lot of clinics have closed, but people there still are interested in reproductive health care, including abortions.
Right. Restricting or banning abortion does not make it go away. And we know this because in the global context, in places where abortion is highly restricted or banned, it's not that people don't get abortions. In fact, they get abortions at the exact same rate that people get abortions in places where it's readily accessible. But it means that people have to turn to oftentimes illegal or sometimes unsafe means to get an abortion. And in this case, it means that people may have to travel significantly out of state and very long distances to get abortion care, meaning from Texas to New Mexico or to other places to get the care that they need.
And what kind of risk does that bring?
So I think, it's important to recognize that it can be really expensive. In fact, the New York Times just published an article last week that talked about the high costs of obtaining an abortion post-Roe. And between just the cost of the abortion care itself, either an in-clinic abortion or medication abortion, even an early abortion in the first trimester, if you add on the expenses of travel, housing, childcare, et cetera, it can be $3,000 to $6,000 for someone to be able to navigate all of this and to get an abortion, even an early abortion, right? And it's important to know that this is falling on people disproportionately with lower incomes who have fewer resources to cover these costs, people who may not have paid time off from work to be able to travel out of state, people who may be facing losing their jobs for taking time off to go out of state and have the care that they need. So I think that's really important to recognize. And we also know that people are turning more to online medication abortion. outside of the formal medical system. There was a recent study done by, again, colleagues from the Texas Policy and Evaluation Project that analyzed requests for online abortion pills to aid access after SB 8 went into effect in Texas in late 2021. And they found that requests for online medication abortion pills coming from other countries more than tripled in the weeks following the implementation of the 6-week ban in Texas. Based on this data, the demand has likely increased even more since June, given more and more states have banned and restricted abortion access. And so you asked about the risks. I think, while medication abortion is extremely safe and effective, there can be legal risks for people in these states obtaining these medications and taking them. And so that's important to recognize.
Now, we've been reading about interference with care of people during pregnancy, not just interference in care of people seeking abortion services.
That's right. I mean, the other effect of these laws are that it's making it really difficult for doctors and providers to provide the best practice clinical training, right, that they've received in cases of early pregnancy complications, including miscarriages and ectopic pregnancies. People are not sure of sort of when they can intervene, at what point. There are exceptions in some of these states for rape, incest, and for the life of the pregnant person or in case of fetal anomaly. But how are these exceptions defined? Who gets to decide? It could be very subjective, right? How much blood does someone have to lose before it becomes life-threatening, for example? And so there's been a chilling effect where people often don't know what they can do and often feel like they have to consult with their general counsel or legal advisors before taking next steps. Whereas, typically what we want to see is that people use their clinical training and decide what's best for the person in front of them based on their clinical scenario, their medical history, and of course, that person's desires and wishes. And now all of that is out of the window, and people really have to make decisions based on what lawyers are telling them and not based on best clinical practice. And that means that oftentimes people feel like they have to make decisions that are out of step with their best clinical training and, could potentially put their license at risk. Having to weigh the risk of criminal charges, right, and fees and fines and sort of legal and issues versus clinical practice and their medical license and doing what's best for the person in front of them. It's a terrible situation, and I feel really awful for my colleagues working in these states and trying to navigate these very regressive laws.
I remember you expressed some concern that exactly this situation would come about when we did a podcast right after the decision. And now it appears to be happening, that the number of people who may be affected is actually quite large.
Absolutely. And again, I think it's important to recognize that that all of these consequences, everything that we're talking about in terms of lack of access to abortion care, lack of access to quality care in early pregnancy, all of these things are impacting people who are already underserved by the medical system historically, right? People of color, people with lower incomes, people living in rural areas, young people, people who already have significant barriers to navigating all of this. And we also have to think about the broader implications on the healthcare system, right? Here in Maryland, we have a number of residency programs, fellowships that provide training to their learners in abortion care, early pregnancy management care, contraception, et cetera. These opportunities are going to be missed in large swaths of these states that are no longer can provide this care and services to their trainees. So even if in a state or, at the federal level, these things are reversed and abortion care becomes more accessible, there will still be a generation of providers who don't have the care and training to the extent that they have it now.
It seems that we may be headed into uncharted territory for the medical profession. You mentioned a couple key issues here. You've talked about the fact that doctors are, on the one hand, weighing the chance that they could get criminally charged against providing care that they've been trained to provide. We certainly heard those concerns on this podcast from the AMA president. And then you also mentioned the fact that clinicians may not be able to get trained in providing comprehensive care or care that's important for reproductive health when there are these state laws in effect. You're an obstetrician, gynecologist. How do you think about the role of the profession in rising to these really unprecedented challenges in the modern era?
I think that's a really great question. And I think number one is many of us went into this work because we wanted to provide excellent care to our communities. We didn't go into this work because we wanted to do advocacy necessarily, or we wanted to talk about politics. But now is the moment where we have to be able to talk about how these laws are impacting our ability to take the best care of patients and communities that we can, right? And so now is the time for all of us to use our voices, to talk to our lawmakers and to tell them that these laws are impacting the quality of care and services, and that they're wrong, right? And I think it's an opportunity for us to take a stand because it will not likely stop at abortion access. We've already seen attempts to restrict access to providing gender-affirming hormone care, for example, and other services to young people in certain states who are trans or non-binary. So this is an opportunity for all of us in the medical profession to take a stand and say that politics don't have a place in the provider-patient interaction, and that really those decisions should be based on science and best practice and professional guidelines, so that we can prevent this from bleeding into other aspects of our care that we care about.
Dr. McDonald-Mosby, thank you so much for coming back, giving us this update. We're going to be covering this important, vital public health issue very closely in Public Health on Call, and we will reach back out.
Thanks for the opportunity.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinell, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Holes Fernandez and Amber Bryan Singletary. Thank you for listening.